Hi, I'm going to be describing a potential interaction between me and a 50-year-old patient who is declining a colonoscopy as a colorectal cancer screening. First and foremost, with every patient, making sure that I'm being a good active listener and demonstrating with my body language, not speaking over them, allowing them to express their concerns. I wouldn't sugarcoat the procedure by any means. It is not the most pleasant procedure, and any procedure carries risks. However, the alternative, which would be treating colorectal cancer, is also very unpleasant. So, I would educate them about the development of colorectal cancer, informing them that most colorectal cancers come from polyps or intestinal growths that occur in about 20% of women and 30% of men. Since the screening guidelines have changed, now it's recommended that patients begin at age 45. The mortality rate of colorectal cancer has decreased. And moreover, screening tests can improve the prognosis by detecting cancer early on to initiate treatment. A colonoscopy can identify and remove precancerous polyps before they progress to cancer. Polyps must be removed for biopsy to determine whether it has the potential to grow like a cancer, because you can't determine this with just the naked eye. Harms associated with the screening include intestinal perforation or dehydration from aggressive bowel preparation. Because this patient is unwilling to undergo colonoscopy, I would discuss other alternative screening modalities with the understanding that an abnormal result requires prompt investigation via colonoscopy. So, there is fecal immunochemical testing. This can be performed annually, where the patient collects a stool sample and sends it for analysis. Another screening option is the multi-target stool DNA, commonly known as Cologuard in the US. The US Preventative Task Force recommends the use of Cologuard every 1 to 3 years. There's also CT colonography, which was previously referred to as virtual colonoscopy. And this is an imaging study that visualizes the GI tract to evaluate for cancerous growths. This does require bowel preparation, and it exposes the patient to ionizing radiation. Additionally, incidental abdominal findings may be visualized and would require further workup. This is recommended every 5 years. It is important, again, to note that an abnormal result from any of these alternatives, other than colonoscopy as a screening, would require ultimately a colonoscopy to investigate the abnormality. Therefore, all screening modalities have the potential for colonoscopy-related complications. Returning to the colonoscopy, it is the most sensitive test, meaning that it has the greatest chance of detecting cancer out of all other screening tests available. Additionally, as we mentioned, the provider or person conducting the procedure can not only visualize polyps but also remove them and send them off for biopsy. If results are normal, there are no polyps visualized or any other abnormalities, the patient can repeat screening in 10 years until the age of 75 with shared decision making.